Okay, so how does the kidney actually concentrate the urine, right? Because we know our urine is much more concentrated than the water that we drink. Well, the main thing here is that we're going to have an osmotic gradient in the renal medulla. So and just kind of backing up. So osmolarity is basically the amount of solute in a fluid or in an area. So as we're looking at the cortex, it's fairly consistent in the there is no osmotic gradient. But then as we get into the medulla, as we get toward these sort of this renal pelvis area, it becomes more and more concentrated. So that means as our the tubular portion of the nephron dips into deeper into the medulla, and as that collecting duct moves back through the medulla, as this gets more concentrated, it will have more of a drawing effect on the water. So let's just, that's in the tube. So let's take a look at this image here. So again, afferent arteriole, we have filtered some fluids out of our bloodstream here at the glomerulus. It's caught by this Bowman's capsule. We've done some reabsorption here in the proximal convoluted tubule. Now, if you look inside here, this is going to be the concentration inside the tubule. So as we move through the descending limb of the loop of Henle, you'll notice this number gets higher and higher because more and more water is being absorbed, so it's becoming more and more concentrated, right? Now, as we move back up the ascending limb of the loop of Henle, now we are drawing out our sodium, our potassium, and our chloride. So we're actually actively taking solutes out of the filtrate in this tube. So actually it's becoming less and less concentrated. Well, great. Now I just concentrated urine, or I should say concentrated filtrate, and now I've taken out some of that concentration. Well, not to fear, we're going to take another tour through the medulla. So you'll notice, again, we're now here in the distal convoluted tubule, some more water reabsorption's occurring, so we're going to start concentrating back up again until we're at the same concentration as our interstitial space. And you don't have to memorize these numbers, but just be aware that as we're going back now from that cortical area back down into the medulla, we're going to reabsorb water, reabsorb water, reabsorb water, until again, we have now reconcentrated the urine. Okay. Hopefully that makes sense to you. One of the key things, and you'll see this in this image, is that you have to have some levels of antidiuretic hormone present. One of the things that antidiuretic hormone is going to do is it's going to insert water channels, so aquaporin channels, into this not the distal convoluted tubule, but rather the collecting duct. And by inserting more water channels, you will be able to reabsorb more water. Okay, and then this water and these solids don't just kind of hang out here in this interstitial space. They are then picked up by the vasa recta and all of these capillary networks in this area. Okay, so as we go down this descending limb of the loop of Henle, we are reabsorbing water, so it becomes more concentrated. As we go up the ascending limb, now we are reabsorbing some of the ions, so we become less concentrated, but have no fear. We are going to reabsorb some water in the distal convoluted tubule and in the collecting duct. Since we're going back through the medulla again, we are then going to and we have aquaporin channels, thanks to our antidiuretic hormone. We are then going to reabsorb water once again, concentrating our urine. Okay, so we have now, as soon as we have gone through our nephron, so again, and if I misspeak in any of these lectures, I apologize, but remember, as we're going through these tubes, it's still the filtrate. As soon as it gets past that collecting duct and there's no more modification, we are now considering it urine. So we have to move the urine from the kidneys down into the bladder. So you'll see urine drains through the papillary ducts into minor calyces, which form major calyces, or calyx is just singular, that then all come together at the renal pelvis, which then goes into the ureter, which then drains into the urinary bladder, and then finally, after being stored in the bladder for some small amount of time, it then leaves the body via the urethra. So let's just take a quick look at our ureters first. They are anywhere, the size is or the length is going to depend on how tall the person is. Obviously, the taller someone is, the longer these will be. And you don't have to memorize any of these numbers. But these extend from the renal pelvis to the bladder. These are also retroperitoneal, so behind that parietal peritoneal wall. And they come in at the posterior portion of the bladder. So they don't come in right at the very top, but they actually kind of wrap around to the back part of the bladder. Now, there is no, I should say, true valve. So there isn't like a flap or anything like that, like we saw in the heart. But there is something called a physiological valve. So meaning the bladder wall will compress the openings as it expands during filling. And so basically there's these openings get compressed so you don't have flow going back up into the kidneys. Okay. There are smooth muscles in the ureters. So the flow of urine is not just gravity, although that is certainly one way in which urine will move as we're kind of upright. It will move from the kidneys down to the bladder. There's also hydrostatic pressure, meaning that as we're producing more and more fluid, the new fluid that's being produced is pushing the prior fluid down toward the bladder. But there's also smooth muscle in the walls of the ureters, so there's actually peristaltic movement. So there's like a squeezing movement. So the same movement we saw in the digestive system is here in the kidneys. That is really important. That basically allows us to produce urine and move it down toward our bladder even while we're sleeping and lying down. If we didn't have that, we'd probably have a backup of urine in our kidneys, which would be very, very bad. And similarly, I mean, if you really think about this, it's also what allows astronauts to produce urine in space where they are weightless. Right? So you'll have seen images of this in the lab portion. So here's our ureter. Here's basically, it's a cross section of that long tube. There's this mucosa layer, which is going to have the sort of dark purple transitional epithelium, as well as this lighter lamina propria around it. You'll notice then there's this darker ring of pinkish purple. That's going to be the muscularis layer. There's an inner longitudinal and an outer circular layer. Again, that's going to what's allowing for peristalsis to occur. And then along the very outside, you can kind of barely see it here in the corners. That's going to be adventitia, and that's going to be loose connective tissue that helps keep the ureters in place. So the same layers we've been seeing now: mucosa, muscularis, adventitia. Now, as far as the bladder goes, it's a hollow organ. Distensible means that it can expand. And again, these are just sort of textbook numbers. The size of someone's bladder will vary on the size of the individual as well. There is this anatomical portion in the posterior wall of the bladder called the trigone. It's, as described here, it's a smooth, flat area that's bordered by the urethral, the openings of the ureters, as well as the opening of the urethra. So it's visually different from the rest of the inner lining of the bladder. It looks like this triangular kind of shape to it. There are rugae in the bladder, so your bladder is capable of stretching. I think we're all well aware of that. Here's that urethra, and then again the orifice. Now obviously the length of the urethra will vary depending on if you're male or female. The male urethra is much longer than the female urethra, simply due to the length that has to travel through the penis versus out the female body. Terms for peeing are urination. I think we're familiar with that. You may have heard of people having to void their bladders or having difficulty voiding their bladders. This tends to be a fairly common term that is used in the medical industry. Micturition is also a term that is used, although less frequently, but all of these mean the same thing, going pee. So basically, what happens when you do, you'll have stretch receptors that are going to send signals to the brain after a certain volume is reached, saying, hey, kind of have to go pee. And so you get that sense that you have to pee before you actually really have to go, which is a beautiful, blessed thing. That means that you have time, hopefully, to find a bathroom, right? Before you involuntarily micturate. For the most part, it's going to be under conscious control. There is an involuntary portion. And again, your brain can initiate the delay of peeing or of micturition, but only for a limited period of time, provided that there's no blockage or anything like that. I think we've all had this experience. You gotta go pee, you gotta go pee, you gotta go pee. And at some point, there's no stopping it. Your bladder is going to void itself. And that it's really important because, frankly, like your bladder can rupture if it overfills. So that is a thing. That is a possibility. So it is really important for you to void your bladder. Social embarrassment is one thing. Damage to your body is another, right? Let's see, what else was I going to say about this? I don't remember. Anyway, fun of peeing. There's your little fun fact. But anyway, it is under conscious control. Again, I hope you all realize that. But delaying it can only be done for a certain amount of time. Now, as I mentioned to you, the urethra in the male is going to be much longer. So here in the male is the bladder. Here is the urethra. And we'll see in a later lecture when we get to the reproductive system. In the male, the urethra is the common passageway for the reproductive and urinary tract. That is not the case for the female. Okay, I'm going to say this many times because I don't know why, but this is something that's just like stuck for some reason. We just don't teach this very well to folks. The female reproductive system has a separate tract for the urethra going from the bladder out the body, which is a separate tube from the vagina. The vagina is a separate pathway to the uterus where babies are born. Not the same. Two different in the female, the same in the male. One of the differences in male and female reproductive systems. We'll talk more about similarities and differences when we get to that section. All right. Well, I will pause there, and if you have any questions, please let me know.